Good evening, friends. We are very excited to meet all of you for this evening IHS Prime Time edition. IHS Prime Time is an edition which takes up and brings you the global talent and knowledge sharing on what is latest in every single subspecialty of minimally invasive surgery. Today, we have a very important speaker from California, Dr. Rockson Liu, who's going to address us on various aspects of robotic hernia repair. We have two most eminent hernia surgeons of the country and this part of the world, Dr. Sarfaraz Baig and Dr. Pallavi, who's going to host Dr. Rockson. So may I have the honor of inviting our president, Dr. LP Thangavelu, sir, to give his presidential welcome. Over to you, sir.
Good evening, friends. Rockson, Sarfaraz, Pallavi, Kanavel, Secretary Satish, and all the viewers, greeting from IAGS. I am extremely happy and honored to be here in this IAGS prestigious prime time program. I congratulate Professor Kanavel for organizing this continuously without any gap. And I really appreciate IAGS is appreciating your efforts, Kanavel.
Thank you, President.
And today's program, we're having a very interesting subject, hernia surgery, reboot, robo. Rockson, if you ask me, some 5-6 years ago in India, only few surgeons were doing hernia surgery all over the country. Now, lot of youngsters have come in and they have taken up hernia surgery in a very big way. Of course, robotic surgery has been just introduced wherever they have purchased bigger hospitals or hospitals with more than 150 bed capacity. Wherever they have robo, they are trying to introduce hernia surgery also there. And of course, in India, anything new will catch up very fast. A lot of potential is there, and many companies are coming out with the new robots. Only cost effective. If it is cost effective, when in tier 2 and tier 3 cities also will be going for robo, and already in tier 2 and tier 3 cities, minimal hernia surgery through minimal access surgery has become very popular. A lot of young surgeons are doing robo. Of course, I am also very curious to know what are the areas of hernia surgery where robo is very much useful. Rockson, Rockson Liu, you are from. Today we have one important speaker from US, Rockson Liu, Alta Bates Summit Medical Center. He is from that hospital, from Oakland, California, and he's a very popular hernia surgeon. He is going to give the talk, and my good friend Sarfaraz Baig, popular teacher and hernia surgeon from Calcutta, and also some youngster, madam, you look very young, but Pallavi, Priya, and both of them are joined. I welcome you all, friends, and today for the next probably maybe 1 hour, going to be a very useful session. IAGS is one of the largest associations in minimal access surgery in India, not only in India, throughout the world, with the life membership of 10,000 life members. One of the biggest Minimal Access Surgery Association in the world, I can say. And we are involving ourselves not only in academic activities, a lot of social activities also we are doing, like whenever there is a calamity like COVID situation, or where there is a flood situation, earthquake situation, wherever there is a calamity, IAGS will be there as first persons, our friends will be there. We do a lot of service there. Apart from this social activities, we involve ourselves in a lot of academic activities. Our fellowship programs, FIAGS, in basic minimal access surgeries, and PALS programs, advanced minimal access surgery, and EFIAGS program, endoscopic fellowship programs, very popular in India. We have awarded fellowships to more than 4,000 persons in basic minimal access surgery, and we have trained and awarded fellowship in advanced laparoscopic surgery, more than 1,000 people. Endoscopic EFIAGS, we have trained more than 1,000 people and make it very popular and awarded the fellowship to all these people. Our fellowship programs are well-structured program. It contains, lecture session, live surgery session, endo trainer, and also, meet the professor sessions. And apart from this, we are encouraging youngsters by announcing various awards. For example, Best Research Award for 5 persons if they do research activities and publish it in our official journal of Minimal Access Surgery. We select five papers, and we are giving 1 lakh Indian rupee to each of our surgeons. Similarly, we are encourage youngsters to publish more and more papers. We select 5 best articles from our JMAS, Journal of Minimal Access Surgery, and give them 1 lakh each for 5 persons. We have created traveling fellowship for 10 young surgeons. They can go anywhere in the country or outside the country, and they'll be given 1 lakh for 10 persons, young surgeons. Similarly, in our annual National Congress, we have created a lot of awards for best presentation, best video presentation. All these details are available in our IAGS website. Apart from that, we have collaboration with many international organizations, ELSA, SAGES, IPSIS, and SAARC countries, and ALS, DBI. In fact, I am going to participate in the ALS DBA program in November, and WCES program in Korea, Busan, Korea, in October. So, a lot of academic activities IAGS initiated and doing continuously. And with this few words about the IAGS, without interrupting this program, I welcome Mr. Rockson Liu and Sarfaraz Baig and all the viewers for this excellent program today. Thank you very much.
So
Thank you, President.
thank you.
Thank
Go
you,
on, Kanagal.
President. It is indeed a very inspiring talk, and I'm sure IAGS under your leadership will take up more programs of higher academic standards. Ladies and gentlemen, now we move on to the academic part of this IAGS prime time. Dr. Sarfaraz has been a friend of us, all of us, and it's a very revered minimally invasive surgeon. And he is part of the executive committee of the Indian Association of Gastrointestinal Endoscopic Surgeons. And he would rather, I would say, he believed minimally invasive surgery is the way out for general surgery. And as early as 2000, he moved into bariatric surgery and GI surgery as a subspecialization. And I'm sure from then on, Dr. Sarfaraz never had a looking back at all. And he's a good friend of all the professional bodies, and is instrumental in creating original research. And together with Dr. Pallavi and other surgeons, he has authored a textbook on exclusive various aspects of the recent part of the hernia, the upcoming technologies. And he is part of the national trial as part of the IAGS research committee. And more so, he is quite active in demonstrating live operative procedures, taking part as a faculty for most of the fellowship initiatives, basic and advanced. And he is right now the vice president for the Hernia Society of India. And he also serves on the Obesity Surgery Society of India and various other national minimally invasive bodies. I'm happy to welcome Dr. Sarfaraz Jalil, sir. And to talk about Pallavi, Pallavi is a very energetic, minimally invasive surgeon, much respected in Kolkata and amongst the scientific circles across the globe. And they work in them. And together, Dr. Pallavi and Dr. Sarfaraz has taken the science of minimally invasive surgery. And by way of publication, it is evident the quality of the work and the quality of academic challenge which they are posing on difficult questions. Ladies and gentlemen, I take immense pride and privilege in presenting Dr. Sarfaraz and Dr. Pallavi to you for this evening. Can you take over, Dr. Sarfaraz and Pallavi? Keep this evening rocking. Over to you guys.
Thank you, Dr.
President,
Kanagavel.
Thank you.
President.
Just for the information, I forgot to mention one thing. We have a national congress at Coimbatore in February 9, 10, 11. And Rockson, I take this opportunity to invite you for our national congress, February 9, 10, 11 at Coimbatore. Okay, Coimbatore is in the southern part of India. You may be familiar with Coimbatore. Coimbatore is very popular for minimal access surgery. In fact, in the earlier years, way back in 1990, minimal access surgery has been started in Mumbai, Coimbatore, Delhi simultaneously. And I welcome you, and I welcome all the viewers. I don't need to invite Sarfaraz. He is also part of the conference. Pallavi, you are welcome for our conference. Thank you.
Thank you, President. Sarf and Pallavi, please take over.
Pallavi, go ahead.
Yeah, thank you, Dr. Kanagavel. And I think we all have been waiting for a very long time to hear Dr. Liu. So, Dr. Liu is a surgeon from Oakland, California, and we know him for his excellent hernia surgery videos with immaculate dissection, immaculate videos and narrations. Is very popular. His videos are very educational, and we saw him speaking on in Hernia Society of India conference just 10 days ago. So, Rockson, it's all yours. Please take it from here.
Well, thank you very much. Thank you, President Thangavelu. That was a very, very impressive summary of your organization. I'm flabbergasted by how much you guys are doing there, how big the organization is. I had no idea until today that the immense popularity of that organization and what you guys are accomplishing. So thank you for letting me know that. And I hope to be more involved in that organization in the future. You know, especially as robotic surgery becomes bigger in India, I can definitely, I would like to get involved. Okay. And then I would like to thank Dr. Kanagavel for the very kind introduction, and I'll see you at HS. And then Dr. Sarfaraz, we've talked a lot. We haven't met in person, so hopefully someday we'll meet in person. Yeah, you're very energetic. I love what you're doing, and let's meet someday. And Dr. Pallavi, and I've never met you before, but I look forward to more interactions. Thank you for the kind introduction. And as everybody's mentioned, I'm a private practice surgeon, and I came on the scene, I think, of hernia surgery and robotic surgery because of my videos. All right, so there's something about my videos that is attracting everybody's attention. I'm not an academic surgeon. I don't publish much. I do a lot of teaching. So I do interact with a lot of surgeons and understand people's mindset and what they're looking for. And I pride myself as the surgeon that kind of connects the last few dots, of surgery. There's academic papers, academic conferences, right? There's a lot of information out there, and surgeons want to try new things because there is the possibility of improving care for their patient. But after academic conferences, after reading papers, they try to do things and they don't get the same results. And it's because of the little details that aren't said in these meetings. And that's what my videos try to show. And I think that's why it speaks to people. So today I'm going to talk about robotic hernia surgery. It's a very broad topic. I have half an hour, so I can really say whatever I want to. I put together a presentation. Hopefully it'll stimulate a lot of discussion. The discussion part is usually the best, right? So I'm going to share my screen. Give me a thumbs up if you can see this. I just want to make sure. Okay, good. All right. So the title is Robotic Hernia Repair. Is it still just hype? There's very few solid papers that support robotic hernia surgery, right? So why am I so gung-ho about it? Why is the world trying to adopt robotic surgery when paper after paper says there's no benefit? So that's what I'm trying to demonstrate today. I'm going to try to help you get into my mind and help you see why I see so much value in robotic surgery. I do a lot of work with Intuitive Surgical, which is the robot I use, of course. So take what I say with a grain of salt. I proctor for them. I'm a lab instructor. I consult for them. I give presentations. I am an advisor for BD just because I do so much hernia that they're interested in keeping me on their advisory panel so that I can advise them on the state of robotic surgery. And again, for those of you who don't know me, I've become popular because of my YouTube channel. I just search Dr. Rockson Liu and you'll find my videos. Lately I've been going to long format videos, 20-minute, 30-minute videos, because I really, really want to dive into the subject matter, since 5-minute videos really don't, I think, capture the essence of a lot of surgeries. Okay. I've been a case observation site for Intuitive since 2018. Every first, third, and fifth Fridays, I have about 2 surgeons come. So far, it's just been from the United States, but I welcome anybody from outside the country. It's a hernia day. I do inguinal hernias, tap ventrals, and usually an ETEP incisional hernia. As I said, I've been teaching the Intuitive courses since 2017. I've taught close to 40 master level courses. Usually there's about 4 or 5 surgeons per course. And I go around the country proctoring robotic surgeons at all different levels, from beginner, their first 10 cases, to advanced surgeons who want to learn ETEP TARS. I'm on some committees at SAGES and ACS just to stay involved. I really enjoy the robotics and video based stuff, so that's where I try to use my expertise. Just a little bit about my background. I trained at Virginia Mason Medical Center in Seattle, Washington. Had no exposure to robotic surgery. Then I did a MIS fellowship at the Cleveland Clinic. Again, no exposure to robotic surgery. And then I joined Kaiser, which is big in California, in 2005, and moved to private practice, which is where I'm at, with the group called First Surgical Consultants, and operate at that hospital, Ultimate Summer Medical Center in Oakland. I've been there since 2017. So I got on the robot in 2014, and just like probably most of you right now, I saw value only in complex hernias, complex MIS cases, foregut cases, colon cases, complex ones, and didn't really see the value in straightforward procedures, right? But today, I really find value across the entire hernia spectrum, also general surgery spectrum, but I'm not talking about general surgery, I'm here to talk about hernias. But I see value in straightforward unilateral inguinal hernias to the most complex, ETEP TAR surgeries and everything in between. So today I'm going to talk to you about why. As I mentioned, there are some randomized controlled trials that show really no benefit, right? The Prove-It trial and the Rival trials are the two big ones that came out of the Cleveland Clinic, showing no benefit for robotic IPOM, right, compared to laparoscopic IPOM, and then robotic TAP inguinal hernia versus laparoscopic TAP inguinal hernia repair. Another great study from Houston, from Mike Liang's group, robotic versus laparoscopic IPOM, randomized controlled trial, no value in robotic surgery. So why am I doing robotic surgery? And why am I so just over the top with robotic surgery? I want to do everything robotically. And it really boils down to the reason why people love my videos, okay? It's the precision that I'm able to achieve with robotic surgery. That precision translates into so many different aspects of surgery, and I'm going to cover that, okay? That precision is something that we've never been able to obtain in the past with laparoscopic surgery or robotic surgery, or open surgery. With open surgery, we just cannot see the detail we're seeing with robotic surgery. With laparoscopic surgery, we just don't have the dexterity that we do with robotic surgery. And that precision, if you take advantage of it, and that's a key phrase, if you take advantage of it, then you will see better outcomes. And you have to know the capability of robotics to be able to take advantage of it. And that's what my videos hope to show, that the robotic operation takes minimally invasive surgery and open surgery to another level. And if you can achieve that precision, then you will obtain that level, and that level is better than where we are now with laparoscopic and open surgery. Okay. So let's talk about inguinal hernias. Okay. So, inguinal hernias is an operation that is all about planes, just like ventral hernias, right? And if you can achieve a certain level of precision, then the entire operation essentially can follow natural planes and be essentially almost a bloodless operation, okay? So whether it's creating that flap in a tapping inguinal hernia or dissecting the indirect sac off of the cord structure, precision really eventually will translate into better outcomes, okay? Now, I know the studies aren't showing that right now, but I guarantee you with time they will, because when you can create cotton candy and see areolar tissue everywhere, you're going to perform a better operation, because at the end of that dissection, you're going to achieve the 9 commandments that these guys have set out, right? We know what a good hernia repair should look like, right? If you follow these 9 commandments, then you have lower complication, faster recovery, less post-op pain, less or no recurrence. I actually aim for 0 recurrence with inguinal hernia repairs right now, okay? I think very few people doing laparoscopic and open surgery can say that. I honestly feel like my recurrence rate could be 0. And it is 0 right now. I don't, nothing in life is 100%, so I don't say it's 0. It's probably 0.0001 or something like that. And low chronic pain, okay? Let me just go through the 9 commandments, or obtaining the critical view of the malpecting orifice, just really quickly for everybody's sake, just to make sure we're on the same page. So Dr. Jorge Diaz and Ed Felix have said, you need to cross the midline to ensure that you get good medial overlap, dissect out the direct defect. Really importantly, you got to go 2 centimeters deep between the bladder and the pubis. Dissect out any femoral hernias, prioritize the cord. This is the second commandment that's really important. Number 3, number 5, prioritize the cord, meaning peel the peritoneum back off of the vas deferens. The testicular of your mesh is not sitting on the peritoneum, and you have good posterior overlap. Look for cord lipoma, because a lot of, quote, recurrences are just pieces of fat inside the inguinal canal. Dissect past the ASIS to make sure you have good lateral overlap, and make sure you cover the entire myopectoral orifice with good mesh overlap. And you want a minimum of a 15 by 10 centimeter piece of mesh. And the 10th commandment, there should be a 10th commandment, which is a hemostatic dissection, okay? And why is that so important? Because, in this picture, you can see I haven't really fully finished dissecting the retropubic space, so I haven't accomplished MPO number 3, the commandment number 5. Also, I haven't finished paralyzing the cord. And these are the most challenging aspects of the inguinal hernia repair, right? Because what happens is first, blood tends to pool here, which makes it more challenging. And the second thing is all the critical structures that you're afraid of injuring are in this area, right? When you're trying to get the commandment number 3 and number 5 done, you can injure all these important structures. And so what happens is, when you get an operative field like this, you tend to slow down because there are a lot of critical structures. The dissection becomes more dangerous, especially with the corona mortis, right? And you're more likely to perform an incomplete operation. And this is why all the hernia studies from the 90s and early 2000s show a high recurrence rate because of the inadequate posterior dissection. And this is where precision comes into play, right? When you have a windshield full of mud or rain, you can't see. When you have an operative field full of blood, you can't see, right? Look at the structures that are waiting to get us, all right? Look at the plexus of veins and arteries that are in the pelvis waiting to bleed. And if your operative field is bloody from the get-go and blood pools down here, you're not going to be able to dissect 2 centimeters deep and get adequate mesh overlap, all right? When your operative field is like this, you can see through that areolar tissue, you can see the blood vessels that are going to come up and avoid them, right? But those blood vessels are obvious, right? Everybody sees them. They're obvious, whether you do a laparoscopically or open, it's obvious. Well, less obvious to most people are these little micro vessels. And any one of these little vessels that they bleed at the time of surgery, whether you're creating your flap, whether you're starting to dissect deeper into the pocket, any of these vessels can start oozing, staining your tissue, and blood begets blood. And then the surgery becomes harder and harder as you move along through this inguinal hernia repair. And that's why the precision from the start of the flap to the end of the operation matters, right? Because once you're in this retropubic space, you don't want a single drop of blood, right? If you can achieve this level of precision, get down to every little vessel and cauterize it with just a little zap of cautery, you can go as deep as you want in here without fear of causing damage to the obturator nerve, to the bladder, to the iliac vessels, whatever structure you're afraid of injuring, you're not going to injure because you can see it. And this applies even to previously operated pelvis, somebody who's had a prostatectomy, somebody who's had radiation, a distended bladder. There's all these different variables that we have to contend with as hernia surgeons, right? There's different types of hernias. Patients come in all different sizes, whether they're obese or super skinny or tall or short, narrow pelvis, whatever it is. When you have that level of precision, then it all funnels into a very consistent, reproducible operation, and then you get more consistent, reproducible results, right? But I would say that if you're not taking advantage of that precision, then your results will be exactly the same as a laparoscopic operation. Because at the end of the day, a tap is a tap, right? We're creating the same size pocket. We're putting in the same size mesh, right? Why should a laparoscopic operation be different from a robotic operation? And I contend that it's the precision that I'm able to get. And that's what's drawing people to my videos, right? I get that level of precision, which makes intuitive sense to folks that, hey, if you can dissect like that, you're probably going to get better results, right? Because if that level of dissection doesn't intuitively help people believe that they're going to get better results, then I wouldn't be here sitting here and talking to you today. And I can tell you that I am getting better results with that level of precision with inguinal hernias. Okay. I'm going to jump to incisional hernias. So, my comparison for robotic ventral hernia is the standard right now, I would say, is the laparoscopic IPOM or laparoscopic IPOM plus repair, right? Nowadays it's, I would say the plus closure of the fascial defect is important, but you still put an intraperitoneal mesh with an adhesion barrier, use transfascials and tacks, right? And it's obvious to a lot of people why robotic surgery is advantageous with ventral hernia repairs, right? Fascial defect closure, as several studies, including this study by Mike Lang, has shown that is important, right? You get less seromas, and patients seem to do better post-surgery, and there's less recurrences. Several studies now are showing that it is easier to close fascial defects robotically, right? Because you're sewing on the roof, you're in an ergonomic position. These are obvious, and this is not the main reason why I think robotic is advantageous. But let me just dive into it a little further. So the ACHQC, used to be called HSQC, looked at the members' fascial closure rate, and robotics is higher than laparoscopic. And when we're talking about big hernias, right, we can still close it. And this type of hernia, 15 centimeters wide, would be very hard to close laparoscopically. So again, there's advantages robotically, which is obvious. Less obvious to people is this. I don't know if you guys know, but with the Da Vinci robot, I can invert the image, swap my instruments, reassign the hands, and sew on the ceiling like I'm sewing on the floor. So this is sewing a fascial defect, an anterior ventral fascial defect, but it looks like I'm closing a laparotomy incision open, right? It's something, more of a gimmick right now, but this is the potential robotic surgery. I do use this image aversion when my right hand has trouble with the angle of approach to the tissue. So I will do image aversion to use my left hand, turn it into my right hand, and make it easier to sew. That's when I use this image aversion. But to dive deeper into why robotic surgery and the precision is beneficial, we just have to look at the state of affairs right now. So this is a study that I'm sure all of you guys know, the Danish National Registry study, showing that we are not doing a great job when it comes to incisional hernia repairs, right? Our recurrence rate is over 10%. 1 in 10, 1 in 8 patients will have a recurrence from our repairs, no matter how we do it, right? Laparoscopic, open, with mesh, without mesh. In the United States, 1 in 6 Medicare beneficiaries will get a recurrence from their laparoscopic or open hernia repair. And we know that with each recurrence, the success rate goes down. So we have to do better, right? We have to do better. And that's the allure of robotic surgery. I also, I'm a general surgeon. I hate intra-abdominal mesh. When I have to go back into the belly, I hate it when there's a piece of intra-abdominal mesh there, because there's bound to be adhesions. And then if there's peritonitis, what I do with this piece of mesh that is now exposed to feculent bacteria, right? Robotics, the precision of robotics basically has given us the possibility of improving outcomes with ventral hernia repairs. Our adhesiolysis should be safer. We can now separate very thin layers, very delicate, layers can now be separated and kept intact. Okay, we can deliver electrosurgical energy very precisely, so that we can be even more hemostatic than we've ever been. Okay, like inguinal hernia repairs, abdominal wall, ventral hernia, incisional hernia repairs is all about fascial layers, right? And if you can stain those fascial layers like you do with inguinal hernia repair, the possibilities open. The ability to perform an operation in a very clean, safe manner becomes more possible, right? And so here's just an example of a ETEP TAR, okay? Again, it's all about fascial layers. Here I'm cutting the posterior rectus sheath to get into the preperitoneal space, right? Here I'm crossing over into the contralateral retrorectus space. I'm going to open up the contralateral posterior rectus sheath to enter the retrorectus space. Again, I'm cutting a fascial layer to enter a plane, right? That precision that I use for inguinal hernia repair applies to ventral hernia repairs, right? As long as you can have that precision, you can do a bottoms-up TAR with very little bleeding, right? It's about cutting through that posterior lamellodentinal blade, cutting through the transverse abdominis to get into and cut through the transversalis fascia and the bottoms-up TAR to get into that preperitoneal space, right? If you understand your fascial layers, right, and you have that precision to be hemostatic, then this operation can proceed very smoothly without the risk of excessive bleeding, postoperative bleeding, potentially injuring bowel because it's hidden in blood, not seeing these very, very fine, thin planes. And this is finishing up the TAR, which is stripping the transversalis fascia off of the transversus abdominis, right? When I do this open, I'm using my finger and bluntly dissecting through it, and it gets really bloody. Now, most of the time, it's not a big deal. You get the small vessels spasm, and they clot, and you don't get excessive bleeding. But in a few patients, that will lead to further bleeding. And not only can you do straightforward incisional hernias, but you can do harder stuff, right? So in the left upper quadrant, ETEP after a previous IPOM. Again, that's about planes too. Stripping the diaphragm during ETEP TAR for big flank hernias. Again, it's about planes, right? And then reducing a giant hernia sac and staying completely extraperitoneally. Again, that's about planes, right? And you see these planes when there's no blood. You don't see these planes when there's a lot of blood, okay? And that's why when I perform surgery, I try to maintain hemostasis. And even as a laparoscopic surgeon, I try to achieve that, but I had a hard time. With robotic surgery, I can't. I can do it most of the time so that I can see these fascial planes. And when I see these fascial planes, not only can I stay in the correct plane and perform the operation I want to perform, but I'm faster because I see it, I just go after it instead of muddling through blood, right? Same with the redo TAR, right? Even though everything's stuck, there's still there's still a plane between the rectus muscle and the posterior lamella of the internal oblique, right? There's still gonna be those planes that should be there at robotic surgery because of the hemostasis will allow you to find those planes. So my routine incisional hernia repair now basically involves restoration of the abdominal wall envelope, right? I do this routinely. I close the defect. I lyse adhesions safely first, if I do lyse adhesions, but most of the time I'm doing ETEP, so I lyse very few adhesions, but I close the defect. I try to fixate the mesh as little as I can, right? Because I'll later talk to you about why fixation leads to more recurrences. Tension-free reconstruction, I can perform component separation. I get a very big piece of mesh in there. And I think that is going to be the key to lower recurrences. It's not all just about tension. It's about the overlap. And I think we haven't overlapped enough in the past. And placing the mesh extraperitoneally because, once you operate on that patient, there's a good chance that patient will need another operation in the future. Probably 20% chance that patient is going to need another abdominal operation. And we should be nice to each other and leave the mesh outside the abdominal cavity so the next surgeon doesn't have a hard time getting back in, right? And I absolutely do all this routinely. And that's because of robotic surgery. So let's talk about safer lysis of adhesions. When I read papers, the first thing I look for is how many enterotomies they got robotically compared to their laparoscopic counterpart. And if they had more enterotomies robotically than laparoscopically, then I know that surgeon has not overcome his or her learning curve. Okay, I don't care how many cases they've done. If they are causing more enterotomies robotically, then they either have not overcome their learning curve or they're not taking advantage of the precision of robotic surgery. As you can see here in this video, I cauterize all those little tiny vessels. I know you're not supposed to use energy around bowel, but I am just sending electricity through that tissue for a millisecond. And having done over several hundred robotic hernia repairs, I have not caused a delayed thermal injury to the bowel in doing this. And so when you do that and you get to the actual bowel mesh interface, then you can actually see that little path of cotton candy, right? And that's how you're going to take this piece of bowel down safely without causing an enterotomy. And then when you get to the part where there's a hernia sac, you can actually see the sac bowel interface, right? So I think lysis of adhesion is safer, and that's a good reason to do ventral hernia repairs. How about fixation? Well, number one, fixation is painful. Whether you tack or use transfascials, it's painful, and all these studies have shown it. But the other issue with transfascials and tacks was demonstrated by this paper published in Surgical Endoscopy in 2009. The authors basically went back and looked at their 505 laparoscopic IPOM hernia repairs, and they actually had video of every single case they did, and looked at the video and tried to figure out why they had a recurrence. I think it was 9 patients where they had recurrence, and all the recurrences were in the line of scar, and 8 out of 9, the recurrence was attached to the mesh. And this is their drawing, and essentially most of the recurrences occurred where the transfascial or the tacks were along the periphery of the mesh, either in the line of scar or in the diastasis. And most patients who have hernias, incisional hernias, midline incisional hernias, have diastasis, and that's part of the reason why they develop hernias. Now, what do we do when we perform an IPOM mesh? We put transfascials, we put tacks, we suture, now with robotic surgery, to the diastasis, and that's going to be a weak point, whether it's in the cephalad location at 12 o'clock or in the caudal location at the 6 o'clock location. That's a weak point. So I'm sure you guys see a lot of this, right? You see tacks, and then you see a hernia right above a tack, right? So I think we can reduce recurrence rates significantly by avoiding those transfascials and suturing and securing the mesh to the diastasis. So the benefit of robotic surgery is in extraperitoneal surgery, the mesh is sandwiched between layers, so I really don't need significant fixation all the way around with the mesh. So I just put a few vicryls to the posterior rectus sheath, okay, when I'm doing a TAP, transabdominal preperitoneal repair. This way I'm not fixating to the diastasis. And where I do close the defect, I'm going to have excessive, 5 centimeter overlap, caudal and cephalad to the defect closure, so that now I get defect closure, I get great mesh overlap, and I don't weaken my repair by fixating to the diastasis, where potentially it could pull through and become a separate new hernia. Same with ETEP. This is a ETEP, I think, right lower quadrant scar. You can see the amount of the size of the mesh I can put in for extensive overlap, and I don't put a single suture to secure this mesh. It's completely reliant on overlap and the fixation provided by friction when the mesh is sandwiched between the 2 layers. So now I think we've created a repair that is no longer weak. Okay, it's not reliant on transfascials that can weaken at the point of fixation. And then, of course, tension-free reconstruction. I think the contribution by Yuri Novitsky and Igor Belyansky is just unbelievable when it comes to robotic surgery. I mean, it's without their 2 techniques and the robot, I don't think we would be where we are today, right? So the first thing is the crossover that Igor described, which is going from one retrorectus space to the other retrorectus space through the preperitoneal space, right? And I just want to remind folks that this is a component separation. So when you're doing a Reef-Stopa type repair, by cutting the posterior rectus sheath, you're able to connect these 3 spaces. But more importantly, Yuri has shown this, and other folks have shown this. Ramirez, when he first described his component separation, talked about this, is that when you cut that posterior rectus sheath, which is the RD in Yuri's study, you get 7 centimeters of fascial advancement on each side, okay, which is significant anterior myofascial advancement, which lets you close some pretty big defects without actually having to do a TAR, right? And so by dividing the posterior rectus sheath, I'm getting anterior myofascial advancement. And how can I access the retrorectus space to cut the posterior rectus sheath? Well, I can do it transabdominally, or I can do it ETEP access now, right? Transabdominally, I can do what Philip Meisams calls a TARP. I call it a TARM, which is put your ports into the abdominal cavity, make a vertical incision just medial to the ipsilateral semilunaris, and then perform the retrorectus dissection, the crossover, and the contralateral retrorectus dissection. You gotta, then you can close the defect, put a mesh, and then close that flap. Or you can do it ETEP. This saves you the need to go into the abdominal cavity and lyse adhesions, and then having to make that incision through the posterior rectus sheath to get into the retrorectus space. And ETEP is my preferred method. I think I'm one of the few surgeons in the world who just loves ETEP. I am an ETEP first surgeon. I don't think transabdominal. Whenever I look at a hernia that is that can be done minimally invasively, as soon as I have an incisional hernia and I think can be performed minimally invasively, I think ETEP. I do have some contraindications to ETEP, but they're very few. And so I'm an ETEP first person because I just think the retrorectal space is a great place to start. There's usually no adhesions, right? It's just a bunch of areolar cotton candy tissue. I don't have to deal with bowel. When I'm taking down the hernia sac, yeah, 80 to 85% of the time I do enter the abdominal cavity through the sac, but that's all I have to deal with. I don't have to deal with the adhesions in the rest of the abdominal cavity. And like I said, the posterior rectus sheath division is a component separation. So I can close, moderate sized defects, 6 to 12 centimeter defects frequently without having to do any component separation. And then while I'm in this retrorectus space, I can add a TAR. I can add a partial TAR. I can do a bottoms up TAR part way. I can do a top down TAR part way. I can do a one-sided TAR. I can do a bilateral TAR. I can just do bilateral upper TARs to access that subdiaphragmatic space. So it's a very, very flexible technique, and I can tailor the operation and the dissection and the space I create and the size of the mesh to the patient's hernia characteristic and to the patient's characteristics. And then, as I mentioned, I can add a TAR, and the TAR is just simply a very versatile maneuver to help us connect the spaces. So the way I think about incisional hernias now is I got 6 spaces I can combine. The 2 retrorectus spaces, the preperitoneal space. If those spaces are not big enough for my mesh, I perform a TAR and get into either or both flank spaces, right? And then if I need to get under the diaphragm, right, because I need more cephalad coverage in my mesh, I can perform an upper TAR to get into the subdiaphragmatic space. So now when I think about hernias, I basically look at a hernia, examine the patient and say, okay, can I close this defect with just a posterior rectus sheath release? Yes. Then I'm thinking just ETEP and keep the mesh in the retrorectus space. But is that mesh going to be big enough for this defect that I want? Or is this patient obese and I want a big overlap? If I want bigger overlap, I'll do a TAR, not necessarily for the myofascial release to close the defect without tension, but more for the mesh placement, right? And the precision of robotic surgery lets me do all this at will and doing it routinely, okay? So here's an example of a ETEP TAR. This is a patient, I think, with a 12 centimeter, I can't remember how tall the hernia was, but it was 12 centimeters wide. My plan was to do ETEP TAR. I'm starting in the left retrorectus space. The ports are placed just medial to the left linea semilunaris. The video is sped up 4 times, and this is a 6-minute video. So the amount of surgery that takes place in this video happened in 24 minutes. Okay. So you can see I'm in the retrorectus space, which is just a beautiful space. It's all about planes, right? And so, with robotic surgery and the precision of robotic surgery, I can perform this dissection in a very hemostatic fashion and respect the tissue planes that exist in the body, right? And so I'm just clearing out the left retrorectus space. I'm gonna expose the linea alba so that I don't accidentally injure the linea alba in the good part. And then I'm gonna just cut through the posterior rectus sheath, right? And fortunately in this patient, I see fat, and fat is my friend when it comes to hernia repairs. And in the midline, this could be preperitoneal fat, falciform fat, omental fat, mesenteric fat, even fat in geraldus fascia. It doesn't matter. It all comes down, right? As long as it's not bowel, I'm good. I'm not going to injure it. And here I'm around the neck of the hernia, so I'm going to proceed a little bit more carefully. You can see the way I use cautery, just very precise little taps of the cautery pedal, just to get all those little vessels on the ventral side of the posterior rectus sheath. Very few blood vessels exist on the dorsal side of the posterior rectus sheath. So once I perform a little bit of cautery, I cut and there's no bleeding, right? And so what this allows me to do is once I cut through the posterior rectus sheath, I am prepared to see bowel on the other side, right? And without blood, I know that it's bowel when I see it. When blood stains everything, if you cross over through that posterior rectus sheath, you won't be able to tell whether it's bowel or not, and you're more likely to injure it, right? And that's where robotic surgery can be dangerous if you're, performing this operation. You may understand the anatomy, but if your dissection is bloody and you cross over, you have the risk of injuring bowel. And this applies also to laparoscopic ETEP, right? And of course, with robotic surgery, I just have the ability to be more precise. And that's the advantage of robotic surgery, right? Yeah, technically you can do this laparoscopically, but the level of precision in hemostasis is hard to achieve, or harder to achieve laparoscopically. So here I'm going around the sac, the neck of the hernia. Since I'm going to do a bilateral TAR, I don't need to preserve the hernia sac, because once I do the TAR, the posterior rectus sheath will come together quite nicely. If I were going to just perform an ETEP reef stopa repair, I would try to recruit the sac to ensure that I have posterior coverage. Okay, so here I'm completing the preperitoneal dissection. And once I complete the preperitoneal dissection to the contralateral linea alba, I'm going to start cutting the posterior rectus sheath about 1 centimeter away from the linea alba. So you can see this is a very, very kind of standardized, reproducible operation. And most of the time it can happen in a very, very hemostatic fashion. So here I'm, my left-hand instrument, which is called a force bipolar, is used to protect myself from, protect me from myself, right? I don't want damage to linea alba up here. So I use it to guide my posterior rectus sheath division and try to keep it about 1 centimeter away from the linea alba. So there's a xiphoid. So I'm going to perform a little bit of a retro-xiphoid dissection to prep myself for a TAR. And then I'm going to dissect the retrorectus space, get to the linea semilunaris. And so I've done all this in 24 minutes. You can see how it can proceed very quickly when you can see well. You're not guessing as to what's on the other side of the tissue, and so you can move very, very quickly. Okay, I'm going to move on just for the sake of time. So here I have 3 case studies to show you the power of robotic surgery. And these are, of course, more extreme cases, but the benefit I get from these more extreme cases and more challenging cases is the same with a more straightforward incisional hernia. So here's a 77-year-old male with a normal BMI, history of obstructive sleep apnea and stroke. He had a robotic IPOM with ventrolite, which is a coated mesh by Bard. He had a 15 by 10 centimeter ventrolite placed in an IPOM manner using the robot 1.5 years prior to my surgery. And he developed an midline incisional hernia M2, M3 location that was 9 centimeters wide by 8.5 centimeters long. He also had 5 centimeters of diastasis. So what I was able to do was I was able to perform a robotic ETEP reef stopa repair with ports on the left side. What I normally do in these situations where there's intra-abdominal mesh, I stay ventral or anterior to the mesh, and I keep the mesh below me and keep it with the peritoneum. It just becomes like a peritoneal layer. And I was able to put in a 20 centimeter wide mesh that was 34 centimeters long to reinforce his diastasis also. 30 mLs blood loss. The OR time was 3 hours, which is still long, right? My actual operative time cut to close was 155 minutes. And I was on the robot console for 2 hours, and he was discharged the same day. I think most patients will get an open surgery in this case, but this guy with some comorbidities was able to go home the same day. Here's another one. The 79-year-old male, normal BMI, has hypertension, had an open sigmoid colectomy in 2006, a laparoscopic IPOM with Proceed and Ethibond transfascials in 2008. That recurred, so he had another IPOM with a giant piece of mesh, 30 by 35 centimeter Cavadian mesh. The surgeon only used 4 sutures and a lot of absorb attack in 2014. And then I think 2 years ago, he saw me, so I performed a robotic repair. He had a 50-centimeter wide defect. You know, the previous surgeon who put in that cavity mesh just did not perform an IPOM plus, just performed an IPOM repair. So not only did he have eventration, but he also had a recurrence. The mesh had pulled away along the right side of the abdominal wall. So I performed an ETEP with left lateral ports. On the right side, I performed a 3/4 bottom-up TAR. He did not need a full TAR because his recurrence was in the right lower quadrant. And then I performed a 1/3 bottom-up left TAR just to get better mesh overlap. I was able to remove that proceed mesh. And then I put in a 30 by 41 centimeter piece of priatine in the retromuscular space. Took a while to do this. This is his intraoperative video. You can see how big this gap was. And because of the location of the ports relative to his hernia, I actually use image inversion so that the instrument that was my left hand was used as my right hand. And you can see the entire defect was closed. And then a large piece of mesh was put in. Here's another one that gives me ulcers when I think about doing this open or laparoscopic. 51-year-old male, BMI 33, so not overweight. Perforated diverticulitis. He had feculent diverticulitis. He was extremely sick. He had a sigmoid colectomy and a diverting ileostomy. Despite the ileostomy, he got pretty sick again because of an anastomotic leak at the anastomosis. He had fascial dehiscence. He had been taken back. And then eventually he had his ileostomy reversed. He had a small peristomal hernia repaired primarily without mesh. And then when I saw him, he had a 7.5 centimeter incisional hernia that was 15 centimeters long. But you can see his scar went from xiphoid down to almost a pubis, right? And then these folks, you know, even though on CT the obvious hernia was 15 centimeters long, I expect him to have a Swiss cheese defect, right? And with his surgical history, I would be very, very concerned about a frozen abdomen or really bad adhesions. Okay, so I think if I didn't have the robotic option, I would perform an open reef STOPA and try to stay complete extraperitoneally the way Scott Roth has described in JAX before. That would probably be my go-to operation. Try to avoid this guy's abdominal cavity. Fortunately, with the robotic ETAP, I was able to mostly stay away from the bowel, but in crossing over, he didn't have a lot of peritoneum, so I did encounter bowel. But when you approach the bowel in the retrorectus space in the ETAP fashion, you're able to stay. I don't know if you can envision it, but the bowel essentially you can keep it on the floor of your dissection and just stay anterior to it rather than approaching it from transabdominally looking up and trying to take the bowel down. The adhesiolysis is just the conduct of the adhesiolysis is just different when you come in at an ETAP approach. So despite a frozen abdomen, I mean, the bowel was stuck to bowel, and I couldn't figure out what was intraperitoneal. But I was able to stay ventral to all that bowel, get over to the contralateral retrorectus space. And then because he didn't have any peritoneum, I did a full right-sided TAR so I can close the posterior layer. And because he had hernias all the way up to the xiphoid, I also added an upper left TAR so I can get the mesh tucked under the diaphragm onto the central tendon. So I placed a 27 by 41 centimeter piece of mesh. Took 3 hours, cut to close, and he went home the next day, and he's been doing great. So my algorithm is this: I still perform open hernia repairs for small, umbilical hernias, 2 to 3 centimeters. There's a lot of comorbidities. I'll perform a TAP even for the smaller hernias because I think the recurrence rate is too high in the, especially the obese patients or the patients with poorly controlled diabetes. I think the robotic repair is better. And then when the hernias are bigger, I do a robotic ETAP. The pictures on the right, the right upper one, the patient has a skin graft, that I'm going to still do open. So some things still have to be done open. The patient in the right lower quadrant of the screen, he just has a big sac. His defect wasn't that big, so I did a hybrid. I did a robotic ETEP repair, and then I went and excised the skin open, and they can still go home the same day. This was I looked at my data probably about right before COVID. These are where my hernia is greater than 8 centimeters. You can see the average defect's 11 by 17. I'm able to put a 26 by 33 centimeter piece of mesh on average. OR time is long. These are just challenging cases. Length of stay is 2.1 days. Okay. Longest follow-up now is about 1,400 days. I've had 2 deep SSIs. I was able to salvage all the mesh, and we can talk about later during the discussion if you guys want. In the patients I'm able to follow up, I've had 0 recurrences. Okay. Here's a guy who had a robotic IPOM that recurred, and I did a robotic ETEP. He's in the recovery room. I just wanted to see how he felt. And he scared the crap out of me. He was going to do jumping jacks. I said, stop. And that's how good these folks can feel, right? I can do a really good hernia repair, and they can feel amazing afterwards. I'm not saying all patients get this kind of result, but it's nice to know that we can achieve this. So in summary, robotic surgery is both an evolution and revolution in surgery, right? An evolution in the sense that it takes what we do minimally invasively to the next level because of the precision. And the revolution is because robotic surgery is letting us do things that we weren't able to do before with minimal access surgery. That precision and hemostasis is really what differentiates robotic surgery from laparoscopic surgery and open surgery. So regardless of what the papers say, okay, I think technique, right, is really important. And the fair comparisons to lap or open surgery should only be made when the true potential of robotic surgery is maximized. Surgeons who want to compare their robotic result with their laparoscopic result really need to be honest with themselves. Are they maximizing the potential of that robot? When they are, then that's when the comparison should be made. So thank you very much, and I look forward to a discussion.
All right. So Rockson, needless to say, I think we've been mesmerized with all those awesome skills that you showed. And very frankly, the point that you made about precision, I think that's something that's pretty well taken. So there have been plenty of questions, and I narrowed it down to 3 major questions for you. So the first question, for the benefit of the audience out here, who are plenty. So let's get to the first question. What do you think is are the right cases for a robotic surgery? We saw you doing some awesome cases with large hernias, big sacs, and I would argue, like a devil's advocate would do, that it would lead to seromas even if we take stitches inside them, and a good go-to procedure would be to excise the sac. So just one of those scenarios, but what is your take on what cases do you select for a robotic surgery as far as incisional hernia is concerned?
There's two ends to that, to the spectrum. One end is, would I do it minimally invasively? If I would do it minimally invasively, I would do it robotically, okay? Because I prefer the precision of robotic surgery over laparoscopic surgery, okay? The other end of the spectrum is, what can I get away with and not have to do it open, okay, with the bigger hernias? So that is more nuanced, and I'm not sure I have time to talk about how I decide between the ones that are kind of on the fence, whether between open and robotic, because it's big or it's complicated. How do I decide whether to do it robotic or open? I would say in general, if I can squeeze the abdominal wall together, and I can do it robotically, okay? A patient with a BMI of 22 with a 15 centimeter defect, I probably can't do that robotically. That person's going to need Botox and going to need everything I can, and may still be a bridge repair open. or somebody with giant skin graft, right? So there's two ends to that spectrum, but I would say anything I want to do minimally invasively, I want to do it robotically. Now, is there value in that, right? So personally, I think I love the precision of surgery, and I think that's going to translate to better outcomes overall. Okay, but when you look at each individual patient, is there going to be a difference between laparoscopic and robotic surgery if both operations proceed smoothly? I don't think there's going to be that much of a difference when it comes to inguinal hernias. Okay, when it comes to maybe smaller hernias, if you are performing robotic ILOM. Okay, because you don't know which case is going to go smoothly and which case isn't, right? You don't know which person's going to have some kind of trap in there that's going to cause your operation to go poorly, right? So I'm looking for that consistent result where 99% of my cases go smoothly because I have this robot tool with me and I'm ready and prepared to avoid, complications. Okay. So.
Right. Pallavi, you want to take the next question?
Yeah. So, Rockson, where do you see this robotics progressing from its current form and structure, where it is somewhat cumbersome, the entire docking process, and this is what a lot of people are put off by because it increases the OT time. Do you see them becoming less bulky, or the docking process becoming easier in future? Do you think people are working on that? Have you come across the research or the newer models?
Yeah, so I'm talking about the current state and the future state. So the current state, there's a myth that it takes a long time to dock the robot. Okay, the robot is a tool, right? And this tool is actually designed very well. It's the people that use this tool that don't know how to use it, and so the docking time takes a while, right? And it's not just the surgeon that needs to know how to use it. The team needs to know how to use it. Your scrub tech, your bedside assistant, the nurse that drives the robot in, everybody needs to know how to use that robot. Just like a Formula One racing team, everybody in the team needs to know how to get that car prepped so that they can take off as soon as they can, right? So for me, docking takes about a minute, okay? From when I tell the nurse to drive the robot in to when the instruments are in and I ungown to go to the console. So it doesn't take that much time, and it takes even less time to undock the robot. So the docking process actually does not take that long. So it's that from that standpoint, it's not cumbersome. It is something that the robot is so big, takes a lot of room, it costs a lot of money. So there is a lot of room for improvement. Okay, and I feel like laparoscopic surgery is going to evolve into some type of technology-assisted surgery. Okay, it may not be a big robot, hovering over the patient, and maybe our laparoscopic instrument becomes more robotic-like. But straight sticks, mechanical, laparoscopy is eventually going to disappear. Right? Our laparoscopic instruments will be smarter, will be computer-driven, technology-driven. So it could be we still hold it at the bedside, or we can go sit at the console when we need to use a big robot that has more precision or whatever. In terms of what I know out there, I think you guys probably know just as much as I do. I'm not privy to a lot of the secretive stuff that's happening out there with these companies. You guys are CMR robot, touch the CMR. I've never touched a Hugo. So you guys actually are ahead of me as far as robotics.
All right.
Thank you, Rockson. Yeah, you were saying.
Yeah, so I'll take the third question, which is there in the chat box, and it's an interesting question. It's been making rounds in plenty of conferences, and it basically goes on like this, that if I'm an open surgeon without much experience in laparoscopic surgery, should I first learn laparoscopic surgery, overcome the learning curve, and then get on to the robotic surgery platform? Or can I go and learn the robotic surgery immediately? So Rockson, what's your take on this brilliant and as well as repeated question?
I don't know what other people have said, but I would say skip laparoscopy. You know, laparoscopic surgery required us to approach the patient very differently, right? It's very hard to do. It required a lot of compromise. It changed our technique. Robotic surgery essentially mimics open surgery. So it's like open surgery, but miniaturized. So once you learn the specifics of the robot, and you'll kind of get used to working on the console, which now there's simulators and there's means of practicing. You can very easily transition from open to robotic surgery. I actually have to undo a lot of the bad habits learned by laparoscopic surgeons. They learn to rip, okay? They don't use their wrist, and they perform surgery, robotically like they do laparoscopically, which negates the advantage of robotic surgery. Okay. So that's my answer.
Right.
Yeah. Pallavi, next.
Yeah. Building up on the same question. So, how should the robotic training be different for a person who's just, for example, a resident or a senior resident, compared to a person who's about 10 years into practice, compared to a person who's 20, 25 years into practice? How do you think it differs, the learning curve differs for all of them?
Oh, that's a tough one. So I would say for the trainees, they will pick it up pretty easily in general. Okay. So it really comes down to the attending that is teaching them. How comfortable are they with the robot? And the learner, the resident may actually become more comfortable than the attending. There are fundamental surgical principles that every surgeon needs to learn, right? And that doesn't change with robotic surgery. But the technical aspect of using the robot can be taught, I think. And if you have a good attending surgeon, then it's easier to teach than the resident having to learn through YouTube. But robotic surgery does fundamentally change the way I approach patients. So the thought process behind that can only be taught with an attending who is seasoned and experienced, right? There's a lot like, how do I decide whether a ventral hernia can be approached robotically? That doesn't come through if you're not experienced with robotic ventral hernia repairs. So the residents will have a hard time learning that. Fortunately, with social media and all the resources available online, virtually, it'll be easier for them to understand the conceptual stuff that occurs with robotic surgery. For the person that's in practice, I think the hardest part is finding time, right? You're in a busy practice. How do you find time to learn robotic surgery? There's no easy way around it. Number one is, I would say, you have to commit to it. Don't do it halfway, okay? If you think there's benefit to robotic surgery, just dive into robotics, assuming you have access. And just like any other sport, right? You go skiing, go biking, or play a musical instrument, you got to practice. And laparoscopy translates a little bit to robotic surgery, okay? But like I said, you don't need laparoscopy to do robotic surgery. And no matter how good a laparoscopic surgeon you are, it doesn't translate to robotic surgery one-to-one, okay? So you got to practice. So for somebody who's 10 years out, 20 years out, I don't care how many years out, it's finding the time and being committed to it. So, Intuitive knows how to train surgeons. They've been training surgeons for like 2 decades now, right? So they know how to do it. As long as you follow their pathway, you'll become successful. But the surgeon needs to have the mentality that they are going to dive into it and go all in with it. It can't be halfway, and it can't be, I'm just going to do 10 cases and that's my learning curve, and then I'm going to take on the hardest case. I'm close to 1,000 cases now, and I don't know if those of you that have followed me for a long time, you can see the improvement in my technique, and I'm still on my learning curve. I'm still getting better because this tool is just, it's got so much depth that you kind of peel the onion as you progress in your experience, and you take more and more advantage of it because it's built in such a way that the human body has a hard time using it to its advantage right away. First 200 cases, you're just barely scratching the surface.
Right. So, Roxanne, while we're coming to the close of this discussion, this probably, Pallavi, you have any more question, or can I shoot the final question?
Please go ahead.
Okay, so this may be the final question. It's pretty late now. And I also think that we have detained you quite a bit and you've answered quite a lot. And the final question is usually the toughest question, Roxanne. And I reserve it for the end because this is like playing the devil itself, not even the devil's advocate. I'm just going to play the devil itself.
Okay.
And the question is that every tool is got its downsides.
Mhm.
And starting from the cost of the robot, which let's not even discuss. I mean, the cost is a cost. It may come down in the future. So that's a downside, but it's something that we all know there's no discussion on it. But there are certain things that needs to be discussed. For example, if I'm a robot, if the robotics does not allow us a tactile feedback, and although the visualization is fantastic, it still doesn't give us the feel of what's holding. Now, between the laparoscopy and robotics, laparoscopy itself, the sticks itself gives some sort of a feedback compared to robotics. In robotics, I can break a needle. In robotics, I can break a thread. In robotics, I can actually, because I do not have a tactile feedback, I even injure a bowel if I'm not holding it gently. So that's A. And the other thing is when I'm making the ports, I have to be 7 centimeters apart or 8 centimeters apart, away from the costal margins and the bony prominences. And those things do not matter in the laparoscopic surgery because I understand that if it's going to hit, I'm going to be careful. Whereas in robotics, I can't be as careful as it is desirable. So for a cholecystectomy, for example, the robotic the robotics arms are going to be very funny placed. The port position is going to be very funny. And even for I-forms or TARUP, the port position at times the flank doesn't give you enough space to put in 3 ports. Plenty of areas where you have to innovate, you have to plan before you go for the surgery. All that happens because we are trying to make the robot work and achieve the outcome. As I said, I'm just playing the devil, so don't get me wrong here. I'm just playing the devil as best as I can. And finally, why not have a hybrid, have a laparoscope instrument as well while doing robotics? Because there's so many things that the laparoscopy can do to help, bringing in the suture, bringing in the mesh, helping in doing good retraction, so on and so forth. So very long question, Roxanne.
Yeah.
Your comment on this, please.
Yeah, my answer won't be very long. So, the way I think about this is I go back to my intern days. I had a attending named John Ryan. You probably don't know him, but he was a very big liver and parathyroid surgeon. And from day one, he harped on me using my left hand to retract properly. And he harped on hemostasis. He was a liver surgeon who really does not like transfusing patients because he believed transfusion was harmful to the patient. Right. So he practiced a very precise technique. And that's the level of precision I try to achieve regardless of how I do my surgery, open, laparoscopic, and now robotic, right? And so when I take an operation and I think about how I'm going to do it, I want to use a robot because I want to achieve that level of precision that I have a hard time achieving laparoscopically and robotically. Okay. And, the current robot, the Da Vinci robot, has shown me that I can achieve a different level of precision that I wasn't able to achieve laparoscopically and open. So that has just opened a new world to me, right? Now, the robot is imperfect, right? It's expensive, it's bulky, the port placement issues are real. And that's where I try to figure out how to make the robot work for the patient at hand so that I can use it to get that precision, right? If another robot comes along and it's cheaper, right? It's less bulky, maybe I can stand at the bedside and I can still get that same level of precision, I would use it. right? I just don't have that robot right now. So I am totally looking forward to competition to Intuitive, so that they can, change their platform and make it so that it's more accessible to everybody, right? Because ultimately, the goal of everything we do academically, right, all these conferences, is to improve our outcome, right? And I've seen that ability to improve outcome by being more precise, right? And so that's what we should try to achieve. It's, that precision is through better just understanding of the tissue, right? Understanding of the planes, understanding of the anatomy, which doesn't require a robot to do that, right? But there are some things that we just can't do technically, laparoscopically or open consistently, to achieve that level of precision, right? And that's where technology comes into play. Now, there are other reasons for technology, like it's going to make us safer because there's going to be guardrails and all the different ancillary stuff that augments stuff, like ICG and different ways to identify tumor. And I mean, all that stuff is also, we haven't even touched that. But the bottom line is, I want to get that level of precision with my surgery, and the Da Vinci robot allows me to do that right now. I have access to it. I think, in my opinion, overall, there's value to it, because overall the cost of complications is something that's hard to measure. And when I do surgery now, I don't even worry. I mean, I travel all the time. I don't worry about my patients calling and needing to be admitted and then having to have my partners cover my patient, because I have so little complications from these ventral, I need to knock on wood, of course, with these big ventral incisional hernias. All those patients that go home the same day, next day, they don't come back to the hospital. I don't worry about it. I can go travel and proctor and give talks and not worry about the patient coming back into the hospital with a deep SSI or skin necrosis or wound infection or seroma infection, all that stuff, right? And what is the cost to all that we have a hard time putting a value to it? So, sorry, I guess the answer is a little longer, but it comes down to the precision. What's important to us, right? And to me, that precision is very important, and I have the ability to achieve that precision today. For those that cannot achieve that precision because they don't have access to a robot, you can still improve your surgery through all these conferences by just understanding the anatomy, the tissue, laparoscopic ETEP, laparoscopic abdominal reconstruction, all that came about because of robotic surgery showed us the possibilities, right? And so we're kind of improving things together, even whether the robot exists in your hospital or not. Yeah, that's my answer.
So great. Rockson, we've got many, many more questions coming in, but frankly, every good thing has to come to an end.
Yes.
And this has been an excellent 1.5 hours, 90 minutes of absolute pure knowledge and skill exchange. And we are really, very thankful to you. I would now like to hand it over back to Dr. Kanagavel, who would probably conclude the process. We cannot answer all the questions in the chat box. I think it gets very late. It's now 10 p.m. in India, and I'm sure Rockson also would like to spend his day in a fruitful manner. So back to Dr. Kanagavel for the final concluding remarks, and Dr. Thangavelu, our president.
Thank you, Dr. President, please.
Hello.
Yes, sir.
It was a wonderful detailed presentation, Rockson. We really are very happy and we congratulate you. And and after your presentation, there was a very good interaction between you and Sarfaraz Baig. It was really wonderful. We all enjoyed. Thank you very much. Thank you very much.
You're welcome. Thank you for the invitation.
Thank you, President. And I have the honor of reaching up to our secretary, Dr. Satish Mida, to give his closing comments and propose out of thanks. Dr. Mida? I think he has some challenges. Thank you, Dr. Rockson. We look forward to meeting you in person very soon. President, thank you very much. Sarf and Pallavi for making this evening really rocking. And I'm sure a lot of clarity has evolved out of this evening's 1.5 hours, which is well spent. I'm sure people will have clarity, those who want to migrate from laparoscopy to robot. And Roxon made it very clear, if you want to spend time learning robotic, you should take off work from what you're doing on a regular schedule. And it's time where you get committed to the newer gadget rather than swapping this and that and eventually not reaching the heights of your finesse and quality of the surgical skills. I'm sure as more and more gadgets come in, as more and more companies come with the more economic version of robot, I'm sure it is matter of time the Indian surgeons and the surgeons across the globe catch up with this important skill. And I'm sure it is going to be one of the very important armamentarium for minimal invasive surgeons who may claim themselves a robotic surgeon at this point of time. There will be clear indications as Dr. Rockson put, what will be his option for a small defect, medium and large defect. I'm very happy to note that he still has open as a number 2 option after laparoscopic one. And then he goes to the complexity of robotic various other procedures. Thank you, Dr. Rockson, for making this evening a possibility. And I thank the President and the entire Executive Committee of the Indian Association of Gastroenterological and Endoscopic Surgeons for allowing us to host event for this month's IAGS Prime Time. And I thank the DocPlexus team for giving a flawless platform. I'm sure a lot of questions will emulate. And Dr. Rockson is available in Facebook and various Hernia platforms. I'm sure he'll be glad to take your questions and give you quick answers. Thank you very much. Good night, IAGS, and good night, all the minimal invasive surgery colleagues all around. Thank you very much. We look forward to seeing yet another academic event in the coming month.
Thank you.
It was a pleasure. Okay.
Thank you, Roxon.
Bye-bye.
Thank you, everyone. Bye.
You're welcome.
Bye.
Bye-bye.